I'm Dr. KUSUMA Kumari, Professor and HOD, Department of Physiology, Mallareddy Medical College, Mallareddy Institute of Medical Sciences, Hyderabad. So today I'm going to explain about the applied aspects of thyroid hormones. Okay. So before that, we'll go through the summary of previous class, like the synthesis of thyroid hormones, what we discussed under 5-6 subheadings. They include iodide trapping, role of sodium and sodium iodide, synport pump, oxidation of iodine, organification, coupling reaction, and release of hormone into the circulation. So we have to explain them in detail in case if it is needed explanation during exams here. Okay, so these are the sequence of events we have to remember and explain in detail. And all these will take place in an order in a one single follicular lining cell in case of a follicle here. So this is one follicle shown with lining epithelial cells, and here you can see how iodide trapping. Here is the synporter pump will be iodide form. It enters and converted into iodine by peroxidase enzyme, and this iodine is conjugated with thyroglobulin, tyrosine to form monoiodotyrosine and diiodotyrosine. These are again organized, organification takes place with thyroglobulin, and they converted into a substance called colloid. Colloid is a store form of thyroid hormones along with the thyroglobulin, which is a glycoprotein. So here in the lumen, we are seeing this colloid storage. So how this T3, T4 are formed? There are three types of hormones, T3, T4 and reverse T3 produced by thyroid follicular cells. And how T3 is formed is combination of one MIT, monoiodotyrosine plus diiodotyrosine combined to form T3, which are already attached to the thyroglobulin filament, lengthy filament-like structure here. So DIT and DIT means diiodotyrosine. Two diiodotyrosines combined to form thyroxine. That is nothing but T4. So whenever there is demand in the body, these hormones should be again released into the circulation by passing through the lining follicular cells here. So from lumen, we call it as apical area, and the outer surface is called basal area here. Okay. So this is how by endocytosis into the cell and then broken down, release it from thyroglobulin and then released out as free hormones like T3 and T4 into the circulation here. So ratio of follicular cell iodine to serum iodine is thyroid serum or thyroid serum ratio is 30:1 in euthyroid individuals. So serum thyroid ratio, serum iodine to serum thyroid ratio. Usually in the follicular cells, 30 units of iodine is stored. And so even though what we need is very less iodine from outside, but still it is trapped by the follicular cells by against concentration gradient. That's why they act as a secondary active pump here. Okay. So what are the normal thyroid levels in our blood? Usually in an adults is T3 levels 100 to 200 nanograms per deciliter of blood, designated as Ng by dl. T4 4.5 to 11.2 micrograms per deciliter of blood. TSH 0.4 to 5 milli international units. MIU by dl. So this is how we have to remember the normal range of values, which are values less than this, okay, or higher than this. We can estimate the condition as hypo or hyper condition of the thyroid hormones in the blood. That's how we can diagnose abnormal conditions of the thyroid hormones. So to summarize the functions of thyroid hormones, easy way of remembering, this is one of the summaries again. Calorigenic action, metabolic actions, metabolic under again carbohydrate metabolism, its role of thyroid hormone, and proteins and fats. Non-metabolic, we can divide them into different other systems. What is the action of thyroid hormones? Non-metabolic major action is on CNS, very, very important action, especially in the infants and newborns, infants, and intrauterine life also. And major action is on CVS, cardiovascular system. And next priority, its action dominant is on the bones, mainly on the epiphyseal region, and other organ systems also still in important is development of reproductive organs and their function, respiratory system, erythropoiesis. Its action is hastened in the presence of thyroid. Otherwise, thyroid deficiency leads to anemia also. On GAT, endocrines, okay, and other systems also it has got. So roughly around 10 to 11 systems to remember, easy way, and give the explanation of each function. So, and how it is regulated, how much hormone should be produced, how much should be suppressed, when should be minimized. All this is called regulation of thyroid hormone or control of thyroid hormones. So this will depend upon an axis called hypothalamo-pituitary thyroid axis. So from hypothalamus, the hormone released is called thyrotropin releasing hormone, TRH, from the hypothalamus. Through portal system, it will act on the anterior pituitary thyrotrope cells and stimulate them to produce the TSH, thyroid stimulating hormone. So through blood circulation, general circulation, it will go to the thyroid glands. Thyrotropin releasing hormone acts on thyrotropes to produce TSH. TSH will act on the thyroid gland follicular cells because they have got the receptors for TSH. So they will stimulate all the steps of synthesis which were shown in the previous slide, and they stimulate the T3, T4 synthesis. Okay. So before going to actual hypersecretion condition, we just discuss in regularly nowadays they are giving the exam as case scenarios of any systems related. So students should find out what could be the cause of the disease by reading the statements given in the case scenarios here. For example, this is one case which is already there in your record also to train you. A 45-year-old female came to the doctor with a history of swelling of the limbs and face, intolerance to cold, weakness and tiredness. She further stated that she has gained weight and developed loss of appetite, constipation, loss of weight, dry skin and hoarseness of voice. On examination, there was non-pitting edema of face and extremities, lips were swollen and the tongue was enlarged. Skin was pale and thick, the hairs were sparse, rough and lustreless. The speech was slow, hoarse and monotonous. She exhibited poor memory, heart was enlarged, ankle jerk was slow, and there was delayed relaxation. So by seeing this, here the first sentence is the age and female it is given. So once you know what is a hypo condition, signs and symptoms in a patient, or hyperthyroidism condition, what are signs and symptoms? If you read all the other clinical features given here, we can come to little conclusion of could be hypo or hyper. Okay. But by seeing the investigation, we may little bit 90% we can confirm what could be the condition here. So here investigations revealed anemia, serum cholesterol 400 milligrams per 100 ml, basal metabolic rate 40%, serum protein bound iodine is 2 micrograms per 100 ml. So here low BMR, serum cholesterol is high, protein bound iodine is very less here, and this is a little supporting feature here. Rather, along with these, if we see the diagnostic test like assessment of thyroid hormones, T3, T4, TSH levels, we can come to almost like 100% confirmation of is it hyper condition or hypo condition. Here the features suggest that 45 years female and all the features are little slowness of condition suggests that there is something like hypothyroidism condition. What could be hypothyroid condition in adults? Here age is very important. So if you see the age of this and hypothyroidism condition, we can suspect this could be the uh, positive conditions supporting myxedema. Okay, myxedema is nothing but hypothyroidism in adult age group, very common in females. So these are the points supporting our diagnosis here. So this is how you have to come to a conclusion. So if the questionnaire is given like what is your diagnosis, can write down hypothyroidism or myxedema. If you write myxedema, you can score directly full marks. If it is only hypothyroidism, maybe half marks can be given. So how do you explain the presence of non-pitting edema is one of the questions asked. Right? So skin normally contains variety of proteins combined with polysaccharides, hyaluronic acid and chondroitin sulfate. In hypothyroidism, these complexes accumulate promoting water retention and puffiness of the face here. So this is the answer for mixed edema. Edema, which is a non-pitting type, is due to all these substances along with the retention of water, which is differentiates from pitting edema, which is seen in other conditions like kidney failure or cardiac failure, other conditions. Okay. Next, why there are neurological manifestations. So thyroid hormones have marked effects on brain development in its deficiency part of CNS affected are the centrocerebral cortex and basal ganglia. So all these indicate that CNS effect of thyroid is deficient here, leading to neurological manifestations. So what are hypothyroidism symptoms generally is weight gain, hair loss, constipation, painful, prolonged menstruation if it is in women, irritability, anxiety, depression, sleeplessness, increased blood pressure and cholesterol, chills, convulsions, increased fatigue. So these are some of the common symptoms we see. So this is a list of showing many more other variety of signs and symptoms in different people. Need not be all the signs will be there in the patients. Okay. And this is a condition of hyperthyroidism. So what is hyperthyroidism? Is nothing but condition with the excessive production of thyroid hormones leading to hyperthyroid condition common, which is an autoimmune disease, is Graves' disease. So if it is not controlled, the excessive activity of thyroid hormones T3, T4 will lead to all exaggerated conditions of normal functions. Its action on CVS, CNS, okay, reproductive system and other systems. We can see many signs and symptoms. One of the symptoms very prominent is called protrusion of the eyeball with the sclera is seen 2/3 protruded from normal eyeball. And usually cornea will be in the center. You can see the circular peripheral area of sclera, which is not seen in normal people. But this is an autoimmune disease where B lymphocytes start producing antibodies against our own thyroid hormone receptor cells. Okay. So they are also able to stimulate connective tissue in the extraocular muscles. Why there is protrusion of eyeball is these antibodies able to stimulate connective tissue in the extraocular muscles and in the dermis of the lower extremity to synthesize mucopolysaccharides, and these will accumulate behind the eyeball, leading to thickening of both the muscle and the dermis and protrude the eyeball towards the front region from the orbital socket here. So And these are other features given here. And even less frequently, patients with Graves' disease develop infiltrating dermatopathy in the skin over the lower legs called pre-tibial myxedema. So there is a little, this myxedema is common. We see in hypothyroidism in adult age group, but this is a pre-tibial myxedema. If it is in some people, it can be seen. So clinical manifestations, other features seen includes increased metabolic rate, BMR is increased associated with weight loss, sweating and heat intolerance, rapid and more forcible heartbeat, tachycardia, muscle weakness and wasting, tremulousness means tremors. They'll have fine tremors on the small joints, mainly the fingers, difficulty concentrating and changes in the hair growth and skin texture. So abnormal immunoglobulins is designated thyroid stimulating immunoglobulins, which will help in the confirmation of Graves' disease, which are found in the blood test showing thyroid stimulating immunoglobulins. Yeah. So in your exams, this is one of the charts kept on for practical exam to identify. So you have to identify it as the heading as exophthalmosis. And what is the condition? You say answering hyperthyroidism. So you have to be having some more knowledge of explaining what are the other features of hyperthyroidism. Condition leads to other features in the other systems. Okay. So this is like this. You have many spotters or charts to explain. So sometimes symptoms noted previously together with a symmetrical enlarged goiter. What is goiter? Is nothing but enlarged gland of the thyroid gland, which is shown as a protruding mass in front of the neck region. So in Graves' disease also we see this enlarged thyroid gland called goiter. So goiter could be possible in hypothyroid condition also. Enlarged gland can be seen in hyperthyroidism also. It can be seen. And it was named as Graves' disease after Robert Graves, who provided one of the first detailed descriptions of disorder in early 19th century. So he's a medical personnel who has explained and given the names. So hyperthyroidism is one of the most common condition in females. So women are much more. So case scenario, I have given this before explaining hypothyroidism, so that if you have a good knowledge of hypo condition, hyper condition, depending upon the case scenario, we can find out is it a hypo condition or hyperthyroidism. So women are much more commonly affected than men. Most common cause is iodine deficiency. Most common cause is an autoimmune disorder also called Hashimoto's thyroiditis. Hashimoto's thyroiditis is again an autoimmune disease which is hypocondition, whereas in hyper we call it as Graves' disease. And routine blood test reveals that elevated TSH and depressed T3, T4 or decreased normal levels of T3, T4. So elevated TSH is one of the diagnostic feature, the diagnostic feature to confirm it is a hypothyroidism. Whereas in hyperthyroidism, what happens is TSH levels will be low, T3, T4 will be high. So this is how we confirm this. So this is one of the spotters again kept in your exam to identify what is this condition. So the condition consists of painless goiter, skin changes, peripheral edema. Usually we call it as mixed edema, and people will have constipation, headache, joint aches, fatigue is common feature. And in women, anovulation is also possible if it is a younger age group. So what is goiter is nothing but enlargement of the thyroid gland. Could be hypocondition or hypercondition. This is another spotter kept in your exam without the labeling, just for training you. Previous slide was shown. And so cretinism is one of the condition where hypothyroid condition in newborns, infants or children. So this we can continue in the next class. Okay.